Hello, I'm going to be talking today about Stemi or ST elevation myocardial infarction. So, the specific patient, she reported to the emergency room with complaints of chest pain. She reported mid-sternal chest pain. She described it as a constant throbbing feeling, which began about 3 hours ago. She took 2 extra strength Tylenol at home, and it relieved the pain a little bit, but the pain is worsened with movement. She also said that it radiates down her left arm, and she rated it a 9 out of 10 on a scale of 0 to 10, with 0 being the worst pain, 0 being no pain at all, 10 being the worst pain she's ever felt in her life. She also said that there was no relief felt with hot packs or ice packs either. So with chest pain, there's a couple of different diagnoses that it can be, as well as that it can be related to. So first one, of course, being STEMI or ST elevation myocardial infarction. Next would be a pleural effusion. So it's pretty much accumulation of fluid in between the parietal and visceral pleura or pleural cavity, which you can see here in the top left in this x-ray over here. This chest x-ray, there's fluid down here in the bilateral lobes. And then the next one would be possibly costochondritis, which is inflammation of the sternum. Gastroesophageal reflux disease, or GERD. This is when the stomach acid repeatedly flows back into the esophagus, and this can then irritate the lining of your esophagus. And then lastly is anxiety. Things like panic attacks, recurrent panic attacks, can really cause chest pain a lot of times. As far as the pathophysiology of what an NSTEMI is, or STEMI, so this happens when an occlusion of the main coronary artery occurs in the heart. This leads to ischemia and eventually myocardial injury or possibly necrosis of the tissue. So this is usually caused, can also be caused, by spontaneous coronary artery dissection or SCAD. This is when a tear occurs within the layers of one or more of the coronary arteries, which then causes blood flow to slow down or possibly blocks blood flow completely to the heart, which leads to a heart attack. Other causes can be after procedures such as CABG or PCI. Just having that heart go under so much trauma and stress can cause for the heart to have a heart attack. So a PCI, that is when a stent is placed in a narrowed blood vessel that's been partially or completely occluded due to atherosclerosis. And then CABG, that's when they use a healthy blood vessel from one part of the body. Usually they use a leg, or they can do the arms, different locations like that, and they then connect them to blood vessels above and below the blocked artery, and it then creates a new route for blood to flow that bypasses the narrowed blocked coronary artery, hence the name bypass graft. So as far as clinical manifestations, main one, of course, being chest pain. So they usually will present with chest discomfort or chest pain. Shortness of breath or dyspnea is a common one as well. Palpitations, sometimes just feeling like the heart is going too fast, too quick, just beating too fast for them to catch up to it. Some dizziness sometimes, lightheadedness, feeling like they're going to pass out. And then increased sweating as well can occur. But it's also possible that patients don't have any symptoms at all, which is really scary to think about. And then females usually tend to have some more of the quote-unquote unusual symptoms, or not as often seen symptoms that are can be dismissed often as not being heart-related. And have some nausea, vomiting, shortness of breath as well. Usually the arm pain down the left arm is often seen. Now, with the chest pain, it's really important to, ask patients further questions. Of course, wanting to know old carts, the onset, location, duration, all that good stuff. Important one as well is asking about if it radiates anywhere. Usually it will radiate to the jaw, the neck, the back, arms, abdomen. It's important to know all those sorts of things. Now, across the lifespan, the elderly population, they will have the same symptoms for the most part as a regular adult population. They might also experience some syncope and acute confusion, though. And then MIs tend to occur later in life for women than for men. So Men, usually it'll occur below the age of 60, but in women it usually occurs above the age of 75. But there is a higher mortality in younger women than men when they do have a STEMI. And it's still being studied whether the long-term survival rate for women, how it is in the long run, years afterwards that they have a STEMI occur to them. It's still being looked at. So laboratory and diagnostic studies that are done once a patient comes in with a suspected STEMI, big one, EKG or electrocardiogram. We really want to look at how the heart is conducting, and an ST segment elevation, hence the name ST elevation myocardial infarction, is a really big indicator. So, and it also lets us know in which area the ischemia is occurring. So when we're looking at EKG, if the ST elevation is occurring in V3 and V4, then that indicates an anterior ischemia. While if it's occurring in AVF or 2, then the ST elevation means inferior ischemia. And then blood work, big 3 for cardiac biomarkers that we're looking at is troponin, myoglobin, and creatine kinase or CK. So troponin, this is released into the bloodstream 3 to 4 hours after an MI begins, and it can stay in the blood and can be detected up to 10 days after an MI has occurred or has begun. Myoglobin, this is released into the bloodstream after damage occurs to any muscle tissue, and it becomes elevated 30 minutes after injury occurs. So this is probably the quickest one that can be seen in blood work, but myoglobin can also be elevated in skeletal muscle damage, so it's not specific for an MI. So it's a tricky one to look at. And then lastly, CK, this increases 3 to 4 hours after NMI, and it stays elevated for about 3 to 4 days. As far as management and treatment, once it's diagnosed that the patient does have a STEMI per the EKG and per the cardiac biomarkers, then initially we're probably going to give some sublingual nitroglycerin just to kind of relieve that chest pain, hopefully a bit. If that doesn't do the trick, then sometimes morphine or other sort of pain medications can be given to sort of relieve that chest discomfort that the patient is experiencing. After that, the most common treatment is probably a cardiac catheterization with possible PCI or, like I said earlier, percutaneous coronary intervention, depending on what they find once they're actually inside the arteries. More often than not, in the case of a STEMI, it's just because there's an occlusion. So once they're in there in the cardiac catheterization lab, they are going to place a stent to help widen any narrowed or occluded arteries. So as you can see in the diagram here on the left, this is pretty much the process that is going on inside of the artery when a patient is having a cardiac catheterization with a PCI. So pretty much there is a balloon with a metal mesh stent around it, usually metal, and then the balloon is inflated, and then the mesh is inflated to the desired width, and then it is deflated, taken out with the catheter along with it, but the stent mesh stays there, allowing for there to be a wide enough opening for the blood to continue flowing in a healthy way. After the fact, these patients are more often than not, usually placed on aspirin, beta blockers, statins, P2, Y12 inhibitors such as clopidogrel, and anticoagulants to prevent any future MIs, possible strokes, stuff like that. Cultural and social considerations. So it's pretty well known that a lot of cardiac comorbidities such as hypertension, dyslipidemia, obesity, type 2 diabetes, chronic kidney disease, those things like that, they're very prevalent in the Black and Hispanic population. So with those comorbidities is also, of course, a higher occurrence of MIs, in those populations. But there is more MIs actually in the young and female Hispanic and Black populations as well. But sadly, these populations tend to experience longer delays in care and treatment as well. Their symptoms tend to get dismissed or misinterpreted, or sometimes just not really being believed by others in the symptoms that they're having, and they therefore can suffer worse outcomes compared to white patients or other patients in general. Prognosis wise, it has a pretty good prognosis and expected health outcome. STEMI patients have an expected survival rate of about 94% after a year has passed since their STEMI. But as expected, patients over the age of 75 do have a higher risk of death due to STEMI, even if there is a PCI performed with the stent placement. Teaching-wise, there's a lot that you can teach with this. This is a very traumatic thing that patients can go through, as well as their family. Is really scary for both parties involved. So it's really important that the patient understands and knows that they have to make some drastic life changes afterwards to help prevent a future MI from occurring. So medication adherence, the medications I told you, aspirin, clopidogrel, beta blockers, statins, really making sure that they're on top of that, taking those as prescribed every day or however it's prescribed to really prevent anything from occurring. Following up with the cardiologist and primary care physician as often as needed, whether it be, once a year, annual blood work, an annual echocardiogram, things like that, just to double check everything is looking okay. And then cardiac rehabilitation is another option that's offered to patients after undergoing stent placement as well. Sometimes that can help them with recovery. And then risk factor management. Usually these things occur because the patient is under a lot of stress. They're not exercising. They're having an unhealthy diet. So making sure that they're trying to involve a healthier diet in their life, some exercise, stress management, whether it be reading, walking, watching their favorite TV shows that makes them laugh, coloring, even building Legos, like whatever it is that helps make them happy, stress-free, if that's even possible, but as close to stress-free as possible. And then this little diagram at the bottom, it's a CDC recommendation of trying to recognize a heart attack or an MI, the symptoms, and what to do after the fact. So, knowing the chest pain, the lightheadedness, jaw pain, arm and shoulder pain, shortness of breath, knowing to recognize those symptoms, calling 911 and trying to get treatment as quick as possible. Now with this, it's a little bit iffy because as much as it is important for the family and the patient to be aware of the symptoms, because they can be very nervous, going back home, they're nervous that it might happen again, they want to know what to look for. It's important for them to know, of course, but it can also cause a little bit more anxiety because they are going to be a little bit more on the lookout, and any sort of small little feeling that they can kind of get very anxious and start freaking out, thinking that it's another heart attack. So just be wary of that when teaching patients to be knowledgeable and their families to be knowledgeable about the symptoms. Now, door to balloon is sort of used in a lot of hospitals. It's similar to when there's a stroke alert, trying to get patients in and treated as quickly as possible. So with door to balloon, this is pretty much the time from when a patient arrives to the emergency department with a STEMI, to the time in which they are in the cardiac cath lab and the procedure started. So by the procedure started, this means that the catheter guide wire crosses, it's literally crossing into the skin, into the vessel. That is the end time of that. So they are trying to have a door to balloon time of less than 90 minutes. That's the goal most of the time. And it is obviously associated with lower mortality of the patient within the hospital. What they have found is that a 1 hour delay in this door to balloon time, it's associated with an increase in mortality of 55% by 1 year. And then reducing the door to balloon time to within 45 minutes. So half the door to balloon, the goal of the half the door to balloon time. Then there's a reduction in cases of that mortality within 1 year of those patients passing from the time that they are discharged after their PCI or their stent placement to the time that they 1 year from that point as well. So there's a state benchmark of hoping to have 75% cases done in less than 90 minutes with, again, door to balloon. And then the AAMC would like to see 70% of at less than 60 minutes. So let's see what happens there. These are my references, and I hope you enjoyed.